Welcome back to Sciencing, a series intended to help you better understand scientific research. In this module, we will look at the famous placebo and the not so famous nocebo effects. Many studies that set out to assess if some treatment, some intervention works, or has a specific effect, to be more precise, are randomized, double-blind, placebo-controlled trials. Randomization and blinding and the use of control groups are covered in other modules, well, in one specific module. Here we're going to focus on the placebo part. So we're going to address some fundamental questions. What is the placebo effect? Why are placebos so important? And what makes a good placebo or a good inactive control or comparison? And we'll discuss the nocebo effect on the way. It turns out that believing that something works can help it to work. For example, telling someone in pain that they're receiving morphine is likely to result in some pain relief, even if it's really just an injection of, say, water or saline, most likely. Believing something works can also enhance the effect of something that does work. For example, injecting a low dose of morphine after telling the patient that it is a maximal dose. And doing that may work better than if we tell them we're going to inject a minimal dose. We refer to both of these examples as the placebo effect. Placebo comes from the Latin for I shall please. Placebos are, in theory, inactive substances or sham procedures used in studies to account for the placebo effect, which, as we're about to see, is actually quite varied. It's not just the power of belief. Now, the other side of the placebo effect is the nocebo effect. Nocebo comes from the Latin for I shall harm. A good example is when people receiving a placebo report the same side effects as those associated with the active treatment, based simply on expectation. When it comes to tablets and capsules, colour matters. A review of studies indicated that people associated colours with specific actions. For example, red, orange and yellow were associated with a stimulant effect, while green was associated with a sedative or pain suppressing effect. Blue was associated with a sedative effect, and white had mixed associations across the group that was queried. In a study from India of 600 people, 75% reported using medication colour as a memory aid for adherence. 14% said pink tablets tasted sweeter than red tablets, when in fact there was no difference in sweetener or sugar content. 11% associated white and blue with a bitter taste, and 10% thought of orange tablets as sour. This tells us that expectations, although important, are of course not universal. And that's another argument for randomization of participants as well as having placebo control when called for. The packaging medication comes in also makes a difference, with many people associating different packaging colours with different potencies, for example. There is also research indicating that capsules are perceived as more potent than tablets. Injections are perceived as more potent still, and surgery is the top placebo. It turns out that, getting back to pill colour, in a comparison between blue and orange active sedatives, time to sleep was assessed, and those receiving the blue capsule reported falling asleep more quickly than those getting the orange capsules by an average of just over half an hour. So not exactly inconsequential. Surgeries are not immune to the placebo effect either. One study evaluating the benefit of percutaneous coronary intervention, or PCI, which is the insertion of a stent into a narrowed blood vessel, reported no difference in the improvement of exercise time between those patients who received the actual stent and those who underwent sham surgery. The thing to note is that patients did improve. It just didn't matter whether they were given the actual surgery or whether catheters were inserted and then removed without placing a stent. Similar findings of no difference between actual surgery and sham have been reported for other surgeries. For example, vertebroblasty, for osteoporotic compression fractures. Intradiscal electrothermal therapy, which involves burning nerve fibers. And debridement of tendons in tennis elbow. Now, you may be wondering what evidence was used to support these surgeries in the first place. The answer is that in many cases, earlier studies compared surgery to no treatment or non-surgical treatment. Not really appropriate comparisons, given that the strongest placebo effect is found in general in surgeries, or for surgeries. Having a placebo or having a sham procedure is part of trying to isolate the intervention of interest from all other influences, including but not limited to participant expectations. So, what else are we trying to isolate, or should we be trying to isolate? If we take the medication or supplement example, it may be the extra care, the extra attention, and or the information research participants get that has a positive effect beyond that of what is being evaluated. If we take the surgery example, that all still applies, but there may be other factors as well. There may be post-surgery rehabilitation or some assistive technology. It may even be that the incisions made in the surgery stimulated the body's own healing processes. So, what makes a good placebo or a good sham procedure? A placebo or sham procedure should mimic the test intervention as closely as possible to avoid participants being able to tell what they are getting. For example, the placebo or sham should have the same sensory qualities such as look and feel, or otherwise produce the same experience. This can be tricky, as one way participants sometimes get a sense of which group they are experiencing are side effects, or for that matter, not experiencing expected side effects. Some people have therefore argued that placebos should not be inert, as in really do nothing, but should actually contain substances that can cause side effects related to the test substance. Now, aside from some ethical issues that this raises, there is a possibility that one or more of these substances ends up having other effects that influence the study outcomes. So there really is no perfect placebo, but there should be evidence when you read a study that some careful thought has gone into deciding what the placebo is, what the sham is, or simply what comparison, if it's a study comparing to, if you like, active interventions. So the key lesson out of all this is that many factors influence people's expectations and actual experience of interventions. This is true in research and professional practice. Therefore, studies should include carefully thought out placebo or sham controls, if at all feasible, to try and isolate the effects of the test intervention from other factors that may explain the study findings. Also, there's probably no perfect placebo or sham control. So we still need to think critically about any given study, even if it appears to be well designed and conducted. So never take it at first glance. So again, the nocebo effect is really just the opposite of the placebo effect. In other words, if we believe that something might be harmful, then it may very well end up being harmful. We begin to anticipate side effects if we're informed of them. So this really goes two ways, and that also needs to be carefully considered. If you found this useful, please hit like, hit subscribe, and most importantly, keep watching other modules so you can get better at reading and understanding research. For example, module here,